Professor Padhani, how is prostate cancer diagnosed?
Currently, patients who are diagnosed after a PSA test, which suggests that there's something wrong in the prostate gland, and then a urologist will normally biopsy the gland using anywhere between 10 and 12 biopsies from the rectum, which is ultrasound guided. What you have to remember is that urologists can't see the cancer in the majority of cases. So these biopsies are done systematically, but are essentially blind to the position of the cancer location.
And what is the effect of this kind of a systematic biopsy?
Well, there's a profound effect to this. The bottom line is it leads to underdiagnosis of cancer, of significant cancers. It leads to overdiagnosis of insignificant cancer, and that directly impacts on patients in as much as you get undertreatment and overtreatment, and this is a real mess.
And the biopsy itself, does that have an impact on quality of life?
Yes, biopsies are painful, and there is a sepsis rate which is increasing currently. So there is a sepsis rate of anywhere between 1 to 5%. It's more or less 3% if you look in the literature. But the interesting thing is the bugs that are now getting into the prostate are resistant to the antibiotics. So it's not a completely innocuous procedure.
So with regard to this less than satisfactory approach to biopsy taking and overdiagnosing, underdiagnosing, what is the approach that you're suggesting?
So there is now general agreement, particularly in Europe, that we should be doing an image-guided or directed biopsy in patients who are suspicious. So we would, particularly in the UK, what we're recommending for groups of patients is that they have an imaging test, usually an MRI scan, and then the appropriate biopsy with regard to where the abnormality is located. So it's a double diagnostic approach. One, an imaging test based on MRI, and then a biopsy that either fuses that MRI with an ultrasound or an in-bore MRI directed biopsy.
So on which number of cases has this procedure been used?
There are thousands of multiparametric prostate MRI scans that have been performed throughout the world. And many systematic analyses have shown that it works. There was actually a very good recent systematic analysis looking at whether you should do an in-bore biopsy or whether you should do an out-of-bore biopsy. And the interesting thing is that it does show that the chances of you diagnosing significant cancers increases anywhere between 10% and 30%. But interestingly, the number of biopsies that can be avoided, the number of cancers that can be decreased, the number of insignificant cancers falls very significantly, probably in the region of 30 to 40%, depending on the patient group. So there's a real benefit to this. Not only that, you obtain the diagnosis with less biopsies. So on average, you would use 3, 4, 5 biopsies. With a systematic trust, on average, it's 10 to 12. So it's less than half the number of needles that you require. It's much more precise.
So considering these benefits, why is not every physician using this approach?
Guidelines are changing. And so we are at a point now where we see the change occurring. In the UK, we've already begun to see the change. Even the premier urological association, the European Association of Urology itself, is now looking at new guidelines which will incorporate MRI into the diagnostic paradigm. So we are now in a period of transition. So you will see things change very rapidly.